tranquila, vamos chamar para moderar essa mesa os doutores Eduardo Trindade Barbosa, olha, Enrico, o doutor Luiz Alexandre Essinger, e enquanto ele se dirige, eu pediria para o doutor Paulo Márcio fazer um pequeno comunicado. Na verdade é um challenge, um desafio.
Obrigado, Sérgio. Queria novamente tocar no assunto. Ontem à noite, durante o nosso coquetel, eu deixei a minha pasta igual a de outros 600 colegas aproximadamente num canto, e na hora de sair, a minha bolsa, igual a de 600 pessoas, tinha sumido. A grande diferença é que dentro da minha bolsa tem a placa que eu ganhei ontem, que foi distinguido pela sociedade, tem um livro e tem um exame de um paciente, de modo que o livro eu posso adquirir de novo, ganhar de novo, aliás. Agora a placa é minha. Levei 25 anos para ganhar a placa. E o exame do paciente é dele, de modo que eu preciso que cada um veja a sua pasta, se não está sem querer, não levou. Às vezes a pessoa até nem abriu a pasta, veja a sua bolsa, se não é, por engano, a minha, e devolva lá na secretaria. Muito obrigado.
Vamos começar então a sessão número 12, chamar o doutor Enrico Ascher, falar sobre Full Metal Jacket. Título bastante interessante e instigante.
Muito obrigado. Gostaria de agradecer novamente à organização, a comissão organizadora, por esse belo convite. Certamente eu fico muito feliz de voltar ao Rio. Vou dar aula em inglês. So my talk is about 5 minutes. I'm going to start with the first slide, please. Do you have it? The whole idea of the full metal jacket is because we were not so sure what happens to our patients when we place a stent from the origin of the superficial femoral artery all the way down to the adductor canal where it meets the popliteal artery. We are very liberal in using stentings, and we've been, but we never really looked in our own data to see whether this was worthwhile or not. Again, do not expect the results of stenting and balloon angioplasties to be equal to a bypass operation. That certainly is not even close to this. So, do I have my talk, or? Okay, great. So, let's move on here. So, the concept of full metal jacket. Thank you. So, the concept of full metal jacket is not actually known initially in vascular surgery. Was introduced by the cardiac surgeons, where they stented the entire coronary, or the branches of the coronary, and they coined the name full metal jacket. And the results, despite a 64 millimeter length stent with drug-eluting stents, the results are pretty good, and they continue to do it. So our definition of full metal jacket is when we are within 1 centimeter of the common femoral. 1 centimeter, and we have to go all the way down. And the reason to do that is because either we had residual stenosis that we're unable to open with the balloon, or the plaque recoiled to more than 30%, or we had a flow-limiting dissection. And this is the only example I'm going to show you today. The SFA, although did not look so bad on the right, I don't have the, did not look so bad. It's right at the origin, was pretty diseased, and down here to the popliteal, and the entire segment right from the origin of the SFA was stented all the way down to the popliteal. And this is a follow-up a year after, showing that the vessel was still patent. So the reason we're placing also more stents than usual, than most people, is because we do a lot of these procedures under ultrasound guidance. And we can see more of the plaque and more of the diseased artery than you would see just with the contrast material. This is a typical example where a patient had a normal angiogram, as you see here, and then on duplex we found a severe recoil of the lesion that was not apparent on the angiogram. This is another patient that had more than 50% stenosis of the vessel, But on angiogram, looked like the vessel was barely stenotic here. So if you do it with ultrasound, you're going to find much more disease than you do it you'll find with. I don't understand why the movie didn't go. This is just the way we do intraoperative duplex and the procedure of the duplex scan. It helps a lot to find exactly the origin. Here's the profunda, and here's the superficial femoral artery. This is the common femoral. So with duplex scan, we can know exactly where to place the stent proximally. Much easier than having to repeat the angiogram in different views, and the patient moves or he coughs, and we have to continue to give dye. Here is showing the sheet, the wire, and the balloon being inflated right at the origin. The stent is right here, right at the origin of the superficial femoral artery. Here's the stent, this is the profunda, and now the vessel is widely open. So I recommend placing those stents when they're very close to the bifurcation under ultrasound guidance. It helps a lot. Even when you have calcification such as this, severe calcification locally, we still see the end of the balloon, we see the profunda, and we're able to place the stent despite the severe amount of calcification. And now here it's widely open. It's certainly not so easy to see, but it's not impossible to do despite calcification. And every systole, you see there's nice flow into the superficial femoral artery. And we kept deploying stents under ultrasound guidance too, as long as they are recurrent or there's significant disease, residual disease. We believe that when we dilate it to almost a normal size, that the results will be slightly better than if you just leave it with 50 to 60% stenosis. But again, we don't have a prospective study on that. From January 2007 to December 2010, we found 63 patients where we did the full metal jacket. We followed them with duplex scan in 1 month, 6 months, and 1 year, and we did an angiogram for reintervention in some of these cases. We used the smart stent, the nitinol stent, and we did post-dilatation to almost a normal size, and we placed patients on clopidogrel. Well, those patients that had iliac interventions or other previous SFA interventions, we exclude them because we want to know what's the natural history of this full metal jacket. And we analyze only the primary patency. Remember, it's not recurrent of the symptoms of the patients. Most of the patients were asymptomatic, but it's just the patency. It's just the patency based on a 50% restenosis only. I'm going to move a little bit faster. We did a multivariate analysis of all the factors to see whether there's any incidence. And full metal jacket was used in less than 10% of our patients. It was not that common. So 91% of the other angioplasties in the SFA within that period of time, we did them either with short stent and without this full metal jacket approach. Most of these patients had claudication, actually. They're severe claudication, but they're claudicant, and the rest were for tissue loss and rest pain. The results show, this is just what we found. In 60% of the patients, we had a popliteal intervention in addition to the SFA, and in almost 16%, we have to go below the popliteal because we did not think that the SFA alone would suffice because of the patient's conditions. And this is the primary patency. Remember, it's not occlusion, it's not clinical symptoms, are just 50% or above stenosis, and this is what we found in 1 year. Almost half of them had re-stenosed somewhat. Now, whether you use a shorter stent or full metal jacket did not make a difference in about 6 months. They all had more or less the same percent restenosis. Sorry, I'm going to go back here. We did a multivariate analysis to see what are the factors that causes more restenosis in these patients. We found that diabetes and creatinine over 0.15 are the only single predictors of restenosis in these patients. And here it shows you in diagrammatic form the non-diabetic versus diabetic. And the creatinine, when it's high, certainly it influences the recurrence of restenosis. In about 6 months, didn't really make a difference whether you had tissue loss or rest pain, but claudicants did better than the other patients. But we didn't have enough patients to get a statistically significant difference, but the trend is the claudicants will still do better, even in terms of restenosis. Here shows you the concomitant procedures for patients that had according to the clinical symptoms. So remember, the red pie is the ones that the patient had rest pain. So we only did infrapopliteal extensions, infrapopliteal balloon angioplasties for patients who had tissue loss or rest pain. We did not do that any in claudicants, but maybe we should. we really don't know what's the influence of opening 1 or 2 vessels downstream in terms of increasing the patency of these proximal reconstructions, and it's something we can discuss. Tax D classification did worse, but again, we did not have enough cases to prove that. And in terms of follow-up, 13.5 months was the mean. 41% of the patient reached stenosis, as I said. We had to redo angioplasty in 17 of these, and no interventions in 8, and 1 bypass in 1. In terms of limb salvage, the results were excellent. Remember, most of the cases were for claudicant anyway, so we don't expect the limb salvage to drop dramatically. So, how can we improve those results since they're not perfect? They're not even good enough. Maybe covered stents would be the answer, maybe drug-eluting stents, and I know that there's several studies evaluating this problem now. Thank you very much for your attention.